أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Now I'm starting one of the session which I have already taken. Actually it was recorded, but I was not able to record properly, so I am reloading it. Again I am giving the lecture in a very summarized fashion. This is congestive cardiac failure and it is session number 4. Session number 4 was actually discussed with some of my students which were present at that time. In the previous lectures I have done about the scenario which I have presented in front of you and justification of the left ventricular dysfunction. In the session 2 I have given a detailed account of the management part is concerned. In the session 3 specifically I have spoken about the refractory heart failure and the management of the one of the most important presentation of the acute left ventricular failure, and that is the acute pulmonary edema and management strategies of the acute pulmonary edema and the precipitating factors of the congestive cardiac failure, and you can say I have classified accordingly. The end result was that if the right-sided ventricular failure occurs, the left-sided will, and it will, or it is not manageable, then it will turn out to be involving the left ventricle. If the left ventricular failure occurs and is progressive, then the right part of the heart is involved. It means that both sides of the heart is involved. It is biventricular failure, which is also known as total heart failure, which is misnomer. However, congestive cardiac failure or heart failure, these are the terminologies which we are using. So we are starting this one. I am Professor Syed Ali Haider, and I am the visiting professor of medicine, which I am talking now of the congestive cardiac failure is concerned. My dear colleagues, actually the thing is this: it is very difficult for the congestive cardiac failure to manage because it has the course of declining, and relapses and remissions occur in the natural history of the disease. So the patients do come to us often with the symptoms of the progressive failure. Breathlessness was remitted, now it relapsed. These are the main problems which is going on. So the person do come to us, and in those cases which I have given previously, the management strategy will slightly be modified. What we do is, again I am repeating the same one, that is number 1, complete bed rest, number 2, limitation of the salt to 800 mg per day, restriction of the fluid 35 ml per kilogram body weight per day in sips, and reduction of the preload, and we use usually the diuretics like furosemide, the potassium sparing diuretics, and the very strong diuretic, that is thiazide derivatives. You can use one diuretic, you can use 2 diuretics, dual therapy, triple therapy or tetrad therapy. The only thing is this, that you have to maintain the systolic blood pressure not less than 100 millimeter of mercury. If the patient does not respond, then we go to the other step. there is reduction of the afterload. In the chronic progressive type of the disease, we use actually the ACE inhibitors, captopril, which is the agent of choice in most of the cases. It's 6.25 milligram 4 times a day. 25 milligram tablet is available. It is divided into 4 parts. It is a short-acting drug. After 15 days, we switch to the long-acting ACE inhibitor like enalapril, lisinopril, etc. Ramipril is mostly used by the physicians in this era of the world. You can use the receptor blockers. Receptor blockers, we use dosata in a minimum dose is 12.5 milligram. If the blood pressure is higher on the higher side, 120, 130, even you can use 50 milligram. Valsartan is the drug which is most tolerated drug. It is given in the dose of 40 milligram OD. Now these are the agents which reduce the afterload in most of the cases. There are other agents as well. Now the other part, the other step will be initiated if this also fails. Then we will add inotropic agents. Digitalis is the drug of choice in most of the cases associated with the atrial flutter or fibrillation or rheumatic heart diseases. But because of the complication and adverse effects and because of the lack of monitoring, we are not using this drug. The other drugs are available, isopropanol or isopropanol, etc. Sympathomimetic amines. But because due to the cost effectiveness and unavailability of the drug, we prefer the agent dopamine, which is acting on the kidney as well as on the heart, at the dose of the 2.5 to 3 microgram per kilogram body weight. If patient is normotensive, if it is hypertensive, you can use hypotensive. You can increase the dose to 4 to 5 microgram per kilogram in a drip fashion, 100 ml dextrose. Or you can use the Dovatrix, which will only act on the D1 receptor, that is on the heart. It is usually used in the case of the cardiogenic type of a shock, where hypotension occurs. If this fails, actually we will adding the adjuvant therapy. The adjuvant therapy, at one time Milnacol and related substances are available. They are inotropic agents, atypical type, phosphodiesterase inhibitors. Now here we use the anticoagulants like or antiplatelet agents. There are a lot of chances of the venous thrombosis in these cases because of the poor circulation. So acetyl salicylic acid or clopidogrel can be used. High risk patient, both agents are used. You add also the ISA beta blockers, sympathomimetic activity beta blockers. Carvedilol is the most we use with the alpha effect as well as beta effect. You can use metoprolol, you can use bisoprolol, and you can use the atenolol in a very low dose because of their negative inotropic effects. You are now using the beta blocker in the congestive cardiac failure. There are 3 actions. Number 1, it is anti-arrhythmic agent. Number 2, it reduces the oxygen demand on the heart. Thirdly, it will control the heart rate. It has got a negative inotropic effect, although, but in a low dose, it is beneficial. And then we will also add low dose HMG coproductase inhibitors, and that is, we are using the rovastatin 5 mg or atorvastatin 10 mg. This we are using. Now, if this also fails, then we will add these recent advances. Now, these recent advances are here. evaporating, Evacet tablet. Now it is a very important drug. They are claiming that it is the pharmacological pacemaker. It will enhance the activity of the cyanoated node. It will also act as the coronary vasodilator. So this drug is very beneficial in those cases where there is a normocardia or tachycardia. But we will not use this drug in the case of bradycardia patient because it automatically adjusts the heart rate. You will not take the risk because it will act on the channels and it will reduce the heart rate. That is why we are not using in the bradycardia. It is a very good drug, 5 milligram, then increase it to 7.5 milligram, increasing to 10 milligram per day. Only side effect is in the vision, flushing and the vision. The vision can be, that is the lightning, feeling of lightning in the daytime. Some of the patient, in 10 to 20% of the patient, they observe lighting in the retina. Some flashing phenomena is going on the retina. So the dose can be reduced to 10 milligram to 7.5 milligram. Another agent which is called the sacubitril, naproxen inhibitor, its mode of action, it controls the blood volume by offering many actions. It will combine with the Valsartan, the agent which is receptor blocker you are using as to reduce the afterload. If you combine sacubitril with Valsartan, it is a very, very effective drug. It will be used in the proportion of 24 milligram sacubitril with 26 milligram of Valsartan, 50 milligram tablet. You can use 100 milligram in cases of hypertension. The drug beauty is that it will controlling the blood volume, and it is also reducing the afterload. So this works beautifully. In some of the difficult cases you can add what is called as, in our case, is the ranolazine. Ranolazine hydrochloride, that is Rancard, 500 milligrams sustained release tablet. It will act on the channels in the myocardium, acting as myosin. It will be, the vitamin for the heart. It becomes the vitamin to the heart, and it will definitely increases the contractility of the heart, and it will also cause a coronary vasodilatation. We will add also this. So these agents are helpful in cases of where the remissions are more, or you are not unable to control. In my 90% of cases, I have controlled with ivabradine or with the sacubitril combination with the Valsartan supplement tablet available in the market. So now a case discussion is, which I am discussing a case now. A 65-year-old male with a history of the hypertension, diabetes mellitus, coronary artery disease, and a past history of MI and the 3-vessel CABG was done in 2002, present with worsening disease on exertion. He stated that he occasionally has a dry cough, but denies any recent chest pain, fevers, and there is nothing significant in other than that. Patient said that he usually can get up a flight of stairs if he stopped halfway, but over the last several days has not been able to climb them at all. past medical history, there was a history of the coronary artery disease, as already mentioned out, and cabbage was done in 2002. Hypertension is non-hypertensive, is non-diabetic, and hypothyroidism. All are risk factors for the heart. It will cause definitely leading to the dilatation of the left ventricle, and that is called dilated cardiomyopathy. They are there, these factors are for operative. No allergy, outpatient medication was, thyroxine was given, he was on metformin and was on Norvasc, that is amlodipine. On examination, they have find the hypertension patient and all saturation of oxygen, bicarbonate values. The pulse is 99, temperature was normal. General examination, alert patient, and breathing is more. The tachypnea. On the cardiovascular system examination, there are no murmurs and a normal heart sound were appreciated. Respiratory tract throughout the lungs. It is fine capillary bibasal caps. Basis, lung basis. Abdomen, soft, tender abdomen. And there are no visceromegaly there. But the pitting edema was bilateral in extension is +2. It is moving towards the from the ankle to the knees. Labs for hemoglobin 13.5, WBC 8, and TET 240, sodium 139, potassium 3.8, blood urea nitrogen 18, and creatinine was 0.8 normal. This was the X-ray chest PA view. Here cardiomegaly is visible, is dominant left ventricular hypertrophy according to the radiological marker, and there are signs of the pulmonary edema in this X-ray. On electrocardiography, you see the most important thing. Other than the ST depression are seen in the different leads, in the lateral wall, in the anterior wall, and inferior wall are seen. But what is important I want to show is this. Labeling is very difficult. But you have to label it. This is the P wave, P pulmonary is shown, shows that the right atrial hypertrophy is there, it is missing here, it comes here. And there definitely is going down, U wave, and then there will be after S wave and then T wave. Now here the R wave is actually not present, it is Q wave. Now R appears also not here. R is appearing in the V3. It is slightly escalating in V5 and V6. There is a good R wave. Non-progression or poor progression of the R wave in the precordial leads. These are the characteristic findings in cases of the cardiomyopathy, dilated cardiomyopathy, leading to the congestive cardiac failure. This is a very interesting situation. Management I have already done. What study would you like to check in this patient? Echocardiography and thalamic scan or coronary angiography? What medication would you like to? Yes, I have to check the hemoglobin A1C, try to manage the diabetes first, and then go for the enhancement of my therapy. Rather, I am using amlodipine, I will use the full therapy which was given as on the start of my lecture. I will add also the avabradine because the pulse is 99, 5 milligram. Vital sign do you want to monitor here? The vital sign, always remember the blood pressure and the pulse should be monitored in this patient. Now, a 45-year-old obese woman with a diabetes mellitus is evaluated for a 1 month history of the progressive shortness of breath. 2 months ago, she had a flu-like illness with nausea, vomiting, and the nausea, there is vomiting and sweating. She has not followed up with a physician regularly. One of the her siblings has heart problems and her mother died suddenly and unexpectedly at the age of 55 years. These are the case discussion. Diabetes mellitus. She has got the diabetes mellitus, and on examination, her heart rate 75 per minute, normocardia, and her blood pressure was higher, BMI 32.9, mild obesity, bibasal crackles are positive, are there, regular rhythm, S1, S2 and S3 is there. So the signs of the left ventricular failure are there. There is a mild peripheral edema, jugular venous should be higher, and echocardiogram is significant. The left ventricular hypertrophy and severely decreased systolic function. That is, ejection fraction of the left ventricle was 20% only. And electrocardiogram shows a previous past MI, XHS showed dominant left ventricular hypertrophy. Now this is the typical electrocardiogram. What I want to show is this. Look, the non-progression of the R wave. It appears in the V4 and V5 and V6. There is no evidence in this ECG of the right ventricular hypertrophy or the left ventricular hypertrophy. The axis is normal also. Axis is normal. There are other changes are seen but not significant. What they want? Management. The X-ray, the boot-shaped heart, cardiomegaly there, unfolding of arch of aorta, previous history of the cabbage was seen, and signs of the pleural effusion were also present. Which of the following is the most appropriate next in diagnostic test? Measurement of the plasma BNP, serum protein electrophoresis, cardiac stress test, cardiac catheterization, and endomyocardial biopsy. If it is available in center, it is the most important diagnostic point in cases of the relapse and remission of the cardiac failure, which is caused by the dilated cardiomyopathy. But it is not available. It is a procedure which has got a lot of complications. I will do, the most important is, that is going for the cardiac stress test, because all have been done. The plasma BNP can confirm it, but it is not diagnostic. Serum electron protein electrophoresis is helpful in the certain situations. No, but cardiac stress test, echo or thallium leading to the, again the angiography, these are the best ones. So this is the end of the session 4. I hope that you have enjoyed it probably. I am highly thankful for the listening of this small duration session. Inshallah we will meet again. Assalamu alaikum wa rahmatullahi wa barakatuh.